Hello. We're going to do some different things this year with the muscles. And so I am just going to go over what I think are the most important parts of the muscles out of your Segan Adams musculoskeletal book. And this is going to be very low tech, even though we're using technology to teach. So if you could please take that green book out, and then if you could also make a paper that lists all of the shoulder girdle muscles up at the top. So that would be upper trap, middle trap, lower trap, serratus anterior, rhomboids, pec minor, and levator scapula across the top. And then down on the side, I would like you to write the motions. So upward rotation, downward rotation, elevation, depression, protraction, or abduction, and then retraction and adduction. And we're going to fill this out as we go through the shoulder girdle muscles. Now, first of all, the difference between the study of muscle in 210, this class, versus what you went through in 110 last fall, is that we are going to add on the innervation. So as you look at the muscles, you will notice that it says origin, insertion, and action. Those were the three things that you were tested over and that you memorized in 110. And now we've got to come back, and this is an advanced study, so we're going to pick up the in, which is the innervation. And so I want to talk about the innervation before we get into the actual muscles. And that's why I'm holding this spine. So if you look at the model of the spine, if you would tip it this way, you could see the foramen magnum, which is the hole in the vertebrae as they all the way down the spine. That starts up here at C1 and it goes all the way down. So in the model, this is the spinal cord. And then coming off of the spinal cord are the spinal nerve roots, and they run in pairs. So there's a right and a left, and they start with C1, and then they go on down C2, C3, C4, and etc. Now, there is a C8, and that's not a typo. There is a C8 spinal nerve root. One spinal nerve root runs above it and one below it, and so C7, then C8, and then they all, from T1 on down, correspond to their spinous process. So there is a C8, that's not a typo. And so as much as we can review this, I think the better. If you understand the way that the nervous system, the basics of the way the nervous system is organized, it will make much more sense to you as you're studying the innervation of the muscle. Now, do I get it that it's going to come down to memorization? It does, but I like to teach principles. I don't really want to just teach memorization. Memorization is a very low level of learning, actually. So we want to talk about how the nervous system is organized, and if you can get a hold of that, I think the whole thing will make much more sense. So whenever I'm talking about central nervous system tissue, in this case, I'm talking about the spinal cord and the spinal nerve roots. The nervous system, you can think of it as the electrical system of your body. Just like your house has an electrical system, your body has an electrical system, and that is the nervous system, the central nervous system. So as we talk about peripheral nerves, I'll give you an example of that. But before we get into peripheral nerves, let's just talk about the spinal nerve roots and what's happening there. So these are coming directly off the spine. You see that they're exiting through those holes that the facet joint makes, the inferior and the superior facet, all the way down. That's why if there's a facet problem, if that joint has become locked or hypomobile, it can impinge a cervical nerve root, and then the patient can have radicular symptoms. Now, whenever I talk about symptoms related to the nervous system, I'm talking about pain, I'm talking about numbness, tingling, paresthesia, that's another word for pins and needles, and then anesthesia would be lack of sensation, numbness, nothing there. So if the patient is complaining of those types of symptoms, that is going to correlate with, we believe that something is going awry within the central nervous system. And that can be a myriad of problems. That can be a facet joint, if it's on, just on one side. It could be a herniated disc, like what we looked at last semester on unilaterally. If it tends to be more bilateral or two sides involved, that may be a narrowing, stenosis of the within the vertebral column and surrounding the foramen magnum. So it doesn't necessarily tell us what the patient's diagnosis is, but if we combine it with what they are telling us with their past medical history and maybe looking at some other things, we may be able to put together, and that's what your PT is going to do when they evaluate the patient, put together a working hypothesis of what we think is wrong with this patient. We don't always have the diagnostics yet, especially if you're in an outpatient, and as you know, we can have patients walk in, and for evaluation, that's direct access. So that's why we really have to be on our game and kind of understand what's happening. And you as the PTA will be very important in that process. People change. I could have done the evaluation yesterday or 2 days ago. They're coming in on your schedule and something has changed. So the more that you educate yourself and the more you understand, orthopedics are really anatomy and motion. And so the more that you understand the anatomy, the better therapist that you're going to be. So here we have the spinal nerve roots again. There's a right and a left, and they come down and they're labeled C1 all the way down through the lumbar process, the lumbar spinous processes, and there's that kind of horsetail cauda equina at the very end of the spinal cord. So this is central nervous system tissue. Now another structure that is central nervous system tissue is the brain. And in my model, you can just see the skull. But the skull, is the bony house of the brain tissue, the cerebral tissue. And so these structures are very important. And in fact, they are surrounded and encased by bone, which gives them, more protection. And so an easy way to remember when we talk about upper motor neuron lesions or lesions within the central nervous system, in this case, we are talking about structures that are encased by bone. Once they leave their bony house, then they become peripheral nerves. So as this C1, C2, and all the way down, these nerves are branching out and networking and are innervating the peripheral aspects of the extremities, hence their name, peripheral nerves. And so as you look at your book, you're going to see the name of the peripheral nerve, and those are things like ulnar, radial, musculocutaneous, median, femoral nerve in the lower extremity. That's the name of the peripheral nerve. And then you're going to see, like C5, C6. That's the spinal nerve root, where that muscle's nerve is originating way up top here and then coming on down. So that's the first thing that I wanted to point out with the spinal nerve roots. Now, if you remember from anatomy, and I think this may have been the first video that I did with you guys in 120, each of the spinal nerve roots has a sensory component and has a motor component. And those two ganglion exit from the spinal cord. In the sensory ganglions originate from the dorsal aspect of the spinal cord. The motor ganglion originate from the anterior horn of the spinal cord. And then they come together, and it's a mixed bag by the time they get to the spinal nerve root. And so that's why you've got dermatomes. Dermatomes are going to give you information about sensation on the skin related to this particular nerve root level. So that's the sensory part. That's how we're going to test sensation. We're going to use light touch over the dermatomes to test for sensation. And then the other piece of that is the motor. And those are the muscles. Those are the muscles that these nerve roots are innervating that cause the muscle to contract. So without the spinal cord being intact, and without the spinal nerve root being intact, and without the peripheral nerve being intact, the muscle would not have innervation and therefore would not be able to work. So, we're going to get to the muscles. That's the primary purpose of this discussion. But this is very important because this becomes, it's the anatomy in motion, it's the knowledge, and then knowing where the patient's impairments are. So things like lack of range of motion, pain, weakness, those are going to be the physical therapy signs and symptoms that we are then going to, treat perhaps with therapeutic exercise. So physical therapy is very much rooted in therapeutic exercise. And so that's why it's important that you know these. It is sort of a rite to passage, honestly. There will be one more time that you'll have to study origin, insertion, action, and innervation for your muscles, and that after this year, and that will be for your state boards. So it's going to be a pretty big part of what we're doing this semester, okay? So that's just a little bit about the spinal nerve roots, and so that when you look at the book, you understand that these coming out are networking into peripheral nerves, out into the periphery of the extremity, hence their name, but they're starting up top here at the spinal nerve root level. So the ones on the top part of the spinal cord are going to innervate the upper extremity, the brachial plexus. Those in the thoracic region are going to innervate the thoracic muscle, and those just kind of go around all the way around in rings at each level. And then the lumbosacral plexus is going to be down here lower. These spinal nerve roots are coming out and forming things like the femoral, the obturator, the sciatic nerve, and then innervating the lower extremities. So that is an overall view of the spinal nerve root. So now what I would like you to do is to take out your blue or your green textbook, your Siegen-Adams musculoskeletal textbook, and turn to page 74. This is a picture of the brachial plexus. Now remember, brachia is the word for upper extremity. So you're seeing here that the brachial plexus starts with the C5 spinal nerve root through the T1 spinal nerve root. So those are coming directly off the spinal cord, and then they are forming into, down here at the bottom, you can see roots, cords, and trunks. And then those they are labeled as peripheral nerves, which is what you're seeing with radial, ulnar, median, musculocutaneous, and etc. So I always like to point this out. There is a lot in the back of this book. If you're just used to looking at the muscles, you may want to flip back to the back parts of the book, and you'll get a lot of really good information. And I realize that this is a black and white picture. It's not, we kind of like color, but you're seeing that the brachial plexus again, plexus meaning network. So a network of nerves that are innervating and located in the upper extremity are coming out, and they kind of come underneath the clavicle and down, down all the way to the terminal end of the upper extremity. So, and then you can see they will also have the names of the nerves. So that is on page 74. Now, since we're here, just go ahead and turn to page 75, and I want to talk about just a little bit about the peripheral nerves. Remember that I said that the central nervous system structures, the spinal nerve roots, the brain, the spinal cord, are encased in bone, and that automatically gives them greater protection if there would be an injury. But out here, the nerve root has left its bony house, and it is traveling along the periphery of the upper extremity or the lower extremity. In this case, we're only focusing on the upper extremity. And peripheral nerves are located in close proximity to the muscles that they innervate. So if I mentioned to you that there was a peripheral nerve that, again, had started up higher and right off the spinal cord with the spinal nerve root, but it's coming down, and it would be on the anterior upper humerus. If you think about what muscle is there, and it's been a year since you've studied muscles, but you know that the biceps is in this region. And so you may, if you understand where the nerve is, then you can kind of you should be right where the muscle is. And indeed, the musculocutaneous nerve does run in that fashion. That's what's on page 75. You can see it. It's coming down to the upper part of the humerus. It does not cross the elbow. And so it lies in close proximity to the elbow flexors. And so those are the muscles that the musculocutaneous nerve innervates, are the shoulder and elbow, in particular the elbow flexors. And so you can kind of figure it out if you know the radial nerve is named for its location. It's on the radial side of the wrist and forearm. The ulnar nerve is on the ulnar side. The median nerve runs right down the middle. The dorsal scapular would be on the back side of the scapula. So a lot of the names of the nerves, correlate to their location. So I just wanted to point that out. Now, the other thing about a peripheral nerve is that, think about it again, it's the electricity. It's the electricity that turns on the muscle. And so, it's just like if you want to walk into a room and flip on a light, you're going to flip that on and the light in that room is going to come on. That's how I think of peripheral nerves. They must be intact. They must be non-injured to be able to kind of light up the muscle and to produce a muscle contraction. And so since these nerves are no longer protected by the bony layers of the vertebrae, and in the case of the brain, the skull, they can become more easily injured. This is running right along, the humerus. And so I don't think it's too hard to visualize the fact that if the humerus were fractured, that could nick off, a portion of the nerve and cause nerve damage, and then the patient would have weakness to those muscles that were innervated by that nerve. Now, the wonderful thing about the nervous system is that there's a lot of overlap. And so you're going to see, C5, C6 in terms of innervation. Usually the muscle is not just innervated by one spinal nerve level. It's usually at least 2, sometimes 3, even up to 5 or 6 levels. And so that is very important in terms of what we do, because we can take advantage of the fact that there may be weakness, but we can still develop that muscle. We can still, strengthen it and hopefully turn it into something functional for the patient to use. So the overlapping nature of the nervous system is extremely important for us in physical therapy, and we are very much going to take advantage of that. Now, what I would like to do is let's look at the muscles of the shoulder girdle. And so you're going to want to flip back to the front part of your book, which is page 14. Now then, you should have your muscle list. It's the same one that you had in 110 that we're going to work off of. The only thing different is that you're going to, for testing purposes in just a few weeks, you need to know the N, the innervation, and the peripheral nerve and its innervation. And so I'm just going to highlight areas in the book. I still recommend that you take your note cards and you study off of your note cards. Please do not think that you can learn 40 some or whatever it is muscles in one night. That will not be smart. You really need to start them now. And I generally say, between 5, 6, 7, 8 muscles at a time. Make sure that you're getting those down really well, and then that you're adding on, that same number the next day, and that you're working from that. So I'm not planning on reading all of these, but what I want to do is kind of bring a few things to light that maybe you haven't thought about. I know that you can memorize these. So what I want to do here is just really utilize our time well and talk about what the functional aspect of the muscle is, which is how it's going to relate to physical therapy. So I'm going to leave this to you for study, the way you study from this. I'm going to bring things out of the textbook and try to bring them to life for you. So let's start with the shoulder girdle. And again, I would like you to pull out your paper that has your muscles across the top, and then the actions of the muscles on the downward axis here. And then as we talk about that muscle, just go ahead and put an X where the actions are for that muscle. And we're gonna look at this. So we're gonna start with trapezius on page 14. Now, before we go any further, I want to make sure that you understand shoulder girdle is the same as scapula. Shoulder girdle and scapular muscles are the same. In the clinic, we hear people talk about the shoulder joint, and that is the glenohumeral joint. More specifically, the glenohumeral, the glenoid fossa of the scapula articulating with the head of the humerus. And so when I'm talking about shoulder girdle, I'm talking about the traditional scapular muscles that you've learned. So upper rotation, downward rotation, elevation, depression, retraction or adduction, protraction, abduction. So the first muscle that we see is the upper trap. And again, I'm not going to read this, but I am going to pull some things out. So, you see the fibers there and you see how widespread that particular muscle is. But what I want to point out on the actions are that when you look at upward rotation of the scapula, you're going to have 3 muscles that combine to create upward rotation of the scapula. The first 2 are on this page, upper trapezius and lower trapezius. Isn't that interesting? They are very aligned in very different configurations with their lines of pull, but they are going to combine, and the third one is actually the serratus anterior. So those 3 muscles are going to combine to create upward rotation of the scapula. Now, another important thing to remember is those are combination movements. Upward rotation is named for what the inferior angle is doing. And so as I raise my arm, here's my inferior angle. As I raise my arm, my inferior angle is going to upwardly rotate. So to achieve scapular upward rotation or shoulder girdle upward rotation, I must perform shoulder flexion, abduction, or scaption is like 45 degrees between flexion and abduction. So that will always be the case. I must lift my arm. If you hear me say shoulder elevation, I'm talking about raising my arm. Shoulder flexion, glenohumeral flexion, abduction, or scaption. Then the scapula is moving with it to create upward rotation. So now then, if I want downward rotation, I've got to bring my arm down or perform shoulder extension. So shoulder elevation will always, or scapular or shoulder girdle upward rotation will always accompany glenohumeral elevation. Scapular or shoulder girdle downward rotation will always accompany shoulder extension. That will always be the case. And so what we're going to see is that there are 3 upward rotators balanced by 3 downward rotators. And I guarantee you will see a question about this on boards. So the 3 upward rotators, and by the way, you'll probably see it in my class too. If I've told you this is going to be on the state boards, you know I'm going to do it too. So the 3 upward rotators are upper trap, lower trap, serratus. The 3 downward rotators are rhomboids, levator scap, and pec minor. And so these 3, you have to lift the arm to have these 3 muscles active. You have to lower your arm to have the downward rotators active. That will always be the case. And so what you'll see on the boards is they just take the names of the muscles in groups and, mix them all up, and you have to pick out the one that has the 3 upward or the 3 downward rotators. So we wanted to start off with that. And when we get to shoulder rehab, I'm going to show you a nice visual picture of what that looks like out of your Knies book with the upward rotation. That Knies book gives you lots of really good diagrams. But the other thing that you'll notice that's interesting on here on the innervation is that the trapezius are innervated by spinal accessory nerve, which is actually a cranial nerve. And so if you remember from your anatomy, the cranial nerves are just that. They're contained within the cranium, within the skull. And so even if someone has a very, very high spinal cord injury, where the spinal cord and the spinal nerve roots at that level are severely damaged, they still could have shoulder shrugging action because the upper or the trapezius muscles are innervated by cranial nerves. And so guess what? When we get to cranial nerves, we're going to learn how to test those. And to test spinal accessory, you're going to have the patient shrug their shoulders and see, if they have that action available and if there's weakness. So that's the main thing with the traps. I'm going to bounce around a little bit. Let's go to page 17, the serratus. Very, very interesting muscle. Serratus it's like the sharp part of the knife, those edges. So it's named for what it looks like. And you'll remember that it has its insertion on the front part of the scapula. And so, you have to have x-ray vision looking in to see where that insertion is. It's on the anterior part of the scapula on the vertebral border. But something, and we're gonna have a little bit of discussion here. Go ahead and mark down your actions, abduction, depression, and remember, it is an upward rotator. Now, your textbook says lateral rotation, so I don't know why they've changed the name. I have never seen any other textbook referred to it as lateral or medial rotation, even on the state boards. So lateral rotation in this textbook is upward. So there's our third upward rotator. Upper trap, lower trap, serratus. Those are the three upward rotators. Now remember, they have to combine to lift the arm. What if upper trap is weak? The patient will tend to hike the shoulder to try to get their arm raised. That is a big no-no. That's going to create something called impingement, and we will talk about that. But the other actions of the serratus are abduction, so protraction, and then also some depression. Now you will also see that it stabilizes the scapula against the thoracic wall. That is very important. And so if the serratus is not doing its job to stabilize the scapula up against the thoracic wall, the scapula will wing. And I've got some good pictures of scapular winging. You can just automatically assume that that's probably from serratus weakness. And so I just want to talk about a few ways that you could strengthen that. If you want to strengthen it in the open chain, you could have your patient lying on their back and doing protraction. So I might have weight in my hand and I'm laying on my back and I'm doing protraction. There's the serratus. That's an open chain exercise. If I wanted to strengthen it in the, open chain. If I wanted to strengthen it in the closed chain, I could have my patient do a push-up and then a plus. So that little plus at the end is where the serratus is activating. And so when we get to, looking at some orthopedic protocols, you'll see the push-up plus. Now, I could have the patient do that on the floor. I could also have them do it up against a wall. But the push-up plus is to get the action of the serratus because it does tend to weaken. Now, and what I would like to point out is this little box down here. These little boxes have the rest of the story. Paul Harvey's The Rest of the Story about the muscles. Yes, this has all the traditional stuff, but these boxes are what you're also going to want to look at because they tend to tell the rehab part of things. So I just want to talk about the long thoracic nerve for a moment. Again, it's going to run in close proximity to the serratus, so it's going to be like on this outside portion of the trunk. And so if you've got somebody who is using axillary crutches, the arm pieces are pushing in to that part of the rib cage. That's where the thoracic nerve runs. And so nerves do not like compression, either within the body or outside of the body. So that would be an external force that could be impinging on the long thoracic nerve. That is why we don't generally recommend axillary crutches for long-term use. It's really usually for some type of a lower extremity fracture where the patient is only going to be using those for a short term. If you've got the patient has a long-term problem like rheumatoid arthritis or some sort of spinal cord injury, you'll want to choose Lofstrand crutches. Now, another common kind of mechanism of injury for that nerve is for possibly a female who has had breast cancer and has had radiation to this area. Radiation will obliterate nerve tissue, and it's fairly superficial, to the skin. And so that's why you want to look for winging. If somebody has had breast cancer and radiation treatments, because if the scapula does not move smoothly in an upward direction with those three muscles, let's say that the serratus is impaired, then the scapula is going to tend to rotate downward. And that's where you're going to maybe get, too much action from the upper trap. So in the clinic, if you're working on this, you could put the patient in front of a mirror, have them palpate here and hold that shoulder girdle down while they do their, their range of motion for their glenohumeral joint. So I hope I have really, pointed out how important the upper trap, lower trap, and serratus are, and their combination motion for elevating the arm. And if you've got a shoulder, if you're working on a patient with a shoulder injury, if you've forgotten the scapular muscles, you have really missed the boat. You have really missed a big portion of what they're going to need to rehabilitate.